Hello, hello. My name is Jean-Louis Vincent, or Vincent, and I will have the privilege to moderate this interesting session on the role of point-of-care testing in the early identification and management of sepsis. And our discussions will be focused on a mediator we speak more and more about, and that is the pancreatic stone protein, or PSP. And I would like from the outset to thank the Abionic company for allowing us to have these discussions. There is no doubt about the fact that we need better sepsis markers to identify sepsis, to assess the severity of sepsis, that could orient the patient to the intensive care unit outside the ICU, or it could help to identify the need for very active management of the patient, perhaps with more x-rays, with changing the antibiotics, with calling the surgeon back at the bedside, etc. And we would also hope to have markers that can be followed over time to individualize the duration of the antibiotic therapy and to make sure that we are in the right direction with our current management. So these are interrelated questions, but they are clearly very, very important. And to discuss these aspects, we have three knowledgeable person who have an experience with PSP. We'll have Dr. Klein, who is a surgeon in Aarau in Switzerland. We'll have the Dr. Melegari, who is in anesthesia and intensive care in Modena, in Italy. And we'll have Dr. Lagadinou, who is from infectious disease in Petra, in Greece. So each of them will present for about 15 minutes, and then we will have a discussion, and I will invite people to enter their comment in the chat box. So we have now the program under our eyes. Dr. Klein will start by discussing the background, the clinical evidence, and research on PSP before the two others will address the two other topics. So Dr. Holger Klein, the floor is yours.
Yeah, so thank you for this kind introduction and hello to everyone. I hope everyone can hear me. I'm gonna try to now go to the first slide. Let me see.
As we heard initially, you have to click twice and then it works.
Yeah, now it's coming. Okay, yeah. So thank you again. And I was actually asked to have a talk on the most important research on the pancreatic stone protein, since I was involved in several clinical trials over the last year during my stay at the University Hospital in Zurich. So I have two things to disclose. I'm collaborating with Abionic since 2016, doing and leading several clinical studies, and this lecture is sponsored by Abionic. So first of all, I want to give you a short overview on the evolution of this interesting protein. And it goes actually back to the 1980s, where a protein called the lysostatin was discovered as an inhibitor of the pancreatic stone formation. And this is actually where the name comes from for this new sepsis biomarker, so pancreatic stone protein. This is a 16 kilodalton and 144 amino acid long glycoprotein, and it belongs to the C-type lectin binding protein family. And this family is knowingly involved in inflammatory processes during infections. So the first idea of PSP to be somewhat related to infectious or septic events came up in the 1990s, where they found that PSP binds directly to bacteria and causes their immobilization. but not much attention was paid to this idea, so not much happened actually in the years between the 1990s and the 2000s. It was first Professor Rolf Graf from the Pancreatic Research Lab of the University Hospital in Zurich, who I worked with later on, who did some animal research, and he found that PSP is an indicator of systemic stress in rats in the presence of infection. There were several more animal studies going on and leading to clinical studies like from bench to bedside, where in 2009, colleagues of mine found that the University Hospital in Zurich that PSP is actually highly increased in post-traumatic patients with sepsis. After that, a lot of more patient cohorts with a different background were studied, such as cardiac surgery patients, intensive care unit patients, neonates, or even visceral surgery patients. We found, or we established, normal values, as you can see here down below, around 2015. And based on all this study, which I will focus on in my next slides, based on all these studies, we were able to establish a certain understanding of the mechanism, how PSP actually works in the whole inflammatory cascade with an infection. So this came up at about 2017, and with this idea, the so-called Abioscope was invented and brought into clinical routine, enabling physicians to have point-of-care diagnostic tool directly bedside of the patient. After this, in 2020, a large series of studies on burn patients was done under my lead. I will focus on that in the next few slides. So this is a very important or interesting patient collective where biomarker studies or where sepsis biomarkers can very well be studied. After this, the quality of the studies or the level of evidence increased by producing or coming up with prospective multicentric studies in 2021, and even a meta-analysis with a systematic review was done, which I will show later on. After that, and this is actually the newest research where my colleague will talk about later, is that pancreatic stone protein has some kind of a predictive power for mortality in COVID-19 patients. Okay, but now giving you a clue on the understanding of how PSP works in our body. Once we imagine we have an organ dysfunction caused by an infection, probably in the lungs, the so-called cytokine storm, mainly done by IL-6 and IL-8, is sensed by a remote organ such as the pancreas. So the pancreas has a central role in that cascade of inflammatory sensing. And the pancreas then synthesizes and secretes the PSP into our bloodstream, where it actually has two major functions that are shown here. So one that I already talked about is the direct aggregation and immobilization of bacteria. And one is that PSP binds to neutrophil granulocytes and activates them. And this is done by shedding the L-selectin cell surface protein and by upregulating the beta-2 integrin cell surface protein. Another pathway that is less understood is that PSP might have something to do in tissue repair, but research is still going on and I cannot tell much about this. So coming to the studies, there are a lot of studies. I think up to date it's about 30 to 40 studies, clinical studies on PSP. These are the main clinical findings, and I'm going to focus on about 5 to 6 studies in the next 10 minutes. So certainly one of the most important landmarks that PSP was studied is the study published in the Critical Care Medicine Journal in 2009 by colleagues of mine at the University Hospital of Zurich. And they found that the pancreatic stone protein is highly increased in post-traumatic septic patients. And this is actually shown in these graphs here. So this is the graph for the PSP, the pancreatic stone protein, and for comparison, the CRP and the IL-6. So what can be seen here, the dark gray bars are the septic patients, the light gray bars are patients only with an infection, and the blank bars are patients with an uneventful course, so no sepsis and no infection. And PSP is able to differentiate, as indicated by the asterisks and cross here, to differentiate between a septic and non-septic patient at almost every time point. So this is not the case for CRP and IL-6 over the first 21 days. And likewise, which is probably even more important, is that we see a positive interaction between time and group, meaning that we see a steeper increase of septic patients in the PSP levels as compared to only infected patients or non-infected patients. And this is shown by the non-parallel cause of the biomarkers. I will show this in a later study where it is a little bit more obvious. So this interaction is not given by the CRP and the IL-6. Coming to the next study, performed by Levelin in 2013, also published in the Critical Care Journal, they were able to show that PSP actually correlates with the illness severity. And I want to show you this with this graph here. We can see in the first three boxes, you can see the group with a non-infective series, so only inflammatory stimuli, and this is the group with a sepsis. And not that PSP can only differentiate between the non-infective CS group and the sepsis, which is indicated by those stars. It's also able to differentiate between the severity with an increasing SOFR score. This is also reflected in the ROC curve analysis that can be seen down here, where PSP performed best with an area under the curve of 0.93 as compared to other biomarkers such as the PCT or IL-6 or others. So coming to probably the largest cohort or the largest studies that were under my lead at the University Hospital in Zurich and published 2 years ago in the Annals of Surgery. I already discussed or mentioned it, that these burn patients are a relatively, let's put it like this, valuable subjects for biomarker research because they are heavily burned, so they have a high degree of inflammatory stimuli going on. They spend a long time on the ICU so that you can monitor them very closely. And as another advantage, these patients don't get an prophylactic antibiotic. So this is also always a criticism in studies, but these patients never get a prophylactic antibiotic therapy. So that's why they are very valuable for biomarker research. Coming to the first slide, it can be, or the first graph that can be seen here, this is the PSP and for comparison, the PCT. You can now see, or more obviously, the interaction between group and time, meaning that patients with sepsis, they are marked in orange, raise much more as compared to patients with an infection only or patients with a non-infective course. So this is not the case for the PCT, even though PCT is able to differentiate between those groups at all of the time points. You see that patients with a sepsis raise relatively to the same amount as the other groups do, and this is not wanted for a biomarker. Coming to this graph over here, we try to focus more on the time, what happens before the septic event. And what we did is we rearrange the individual biomarker time course according to the event of sepsis. So this is signified, or this is designated here by this event, and we focus on the days before, and we were able to demonstrate that PSP rises 25 times 72 hours before a clinically apparent septic shock, and by 10 times 48 hours before clinically apparent sepsis. So the same or similar increase can be seen for only septic patients. We have an increase of 3.3 times, 72 hours before the sepsis became overt, and 2.1 times 2 days before the sepsis became overt. For the PCT, in comparison, the relative increase was not as high as for the PCT, as for the PSP, sorry. So only 2.5 and only 1.5. So this is certainly an interesting result of the study. And this is also resembled in the ROC curve analysis. I don't want to give you any details on that. It's just maybe the numbers are a little bit small, but PSP performed best in the ROC curve analysis with an area under the curve of 0.9. The PCT was a little bit lower, and the combining of those bias markers did not bring much. Okay, so then we took a closer look on the impact of the initial burn trauma, which is, how I said before, a very intense inflammatory stimulus. So this is for directly the 2 days after the trauma, and this is for after surgery as an inflammatory stimulus, because these burn patients are operated repetitively during the day during the stay on the ICU. And once we take a closer look at this diagram here, you can see that PSP over the first 2 days is not changing significantly, as you can see here, whereas PCT is increasingly or increases directly after the trauma, probably due to this high inflammatory stimulus. The same is seen as for the CIP, which we expected, and of course we see somewhat a down regulation of the leukocytes, which is caused by the immunosuppression by the trauma itself. Similarly, we could observe this for PSP for directly after the trauma. So our trauma, our surgery does not impact the levels of the PSP directly in the 2 days after it. PCT performed well in this study, one has to say this, but CRP was increased after or in the 2 days after the surgeries. So this already gives, or let me come to the last 2 slides. With an important study done by Pugin and Allen, published in the Critical Care Journal last year. It's a prospective multi-center study. They included 14 ICOs all over Europe with 243 patients. And they actually did the same what we did in our studies, that they rearranged the individual time courses according to the event of sepsis and took a look at what happens before before this event became apparent or was proven. So what can be seen here is the same thing. They found a significant increase even 4 to 5 days before the sepsis was diagnosed. This is not the case for the PCT. I mean, it raises steep, but not as early as the PSP does. And these are the results for the CRP, which increases 2 days in advance. So this is also reflected in the ROC curve analysis in this study, where PSP, CRP, and PCT more or less perform in the same way. But keep in mind that this ROC curve analysis does not take into account the time dependency. So they can only give you a certain result for 1 day. And yeah, this is actually the last study that I want to show you to give you an overview on this interesting protein. It was done or published last year by Prazak, a colleague of mine, and published also in the Critical Care Journal. It's a meta-analysis including 572 patients, and what could be found there is that the area under the curve was the highest for the for our pancreatic stone protein as compared to the CRP or the PCT. This can be seen here with 0.77 and 0.78. Of course, the positive predictive value and the negative predictive value follow that area under the curve. So summarizing, in our hands or from based on these studies, PSP is an interesting upcoming biomarker for sepsis because of two major things. The first one is that we could observe an early and steep increase before the sepsis became clinically apparent or proven. And the second is that it showed a very high level of robustness towards sterile inflammatory stimuli such as the trauma itself or repetitive surgeries. And last but not least, the Abioscope enables a certain kind of a point of care diagnostic to our physicians on the ICU or even on the emergency ward. Thank you for your attention.
Thank you very much indeed, Dr. Klein. Thank you, Holger. That was very interesting. And indeed, it shows that there is a good discrimination between sepsis infection and inflammatory states. And indeed, it works quite well in inflammatory state like burns or post-operative patients. So that sounds very interesting, and we will definitely go back to that in the discussion. Now, I am very pleased to say that we have many people with us, close to 200 participants, which is great for such a webinar. Right now, it's exactly 196 participants watching us. So I'd like to, of course, acknowledge their presence and thank them for being with us. And they will have the opportunity, or they have the opportunity, to raise questions via the chat section. Perhaps there is even another section, but at least the chat section could serve for to put questions. So I have one question, Holger, because we may not return to that later. You said that, interestingly, PSP plays an active role, and it may actually activate neutrophils. Now, activation of neutrophils can have a yin and yang type of action, because on the one hand, we like our neutrophils to be very active against the invading organisms. But on the other hand, we know that leukocytes, when they are activated, they may become harmful for the host. And we know, we discussed it many years ago, their role in the ARDS, and there may be a role in organ failure. So do you see it as an always positive effect, this leukocyte activation?
Well, difficult question, and thank you for these questions. It's probably hard to tell, of course. There is something natural in it, and we are happy that these leukocytes are activated. Yeah, so actually the only study that has been done on that is the one that I showed with the post-traumatic patients, and there they could observe this. But yeah, if it's now sensible or not, or it's hard to tell for me, actually, even as a surgeon. So maybe what would be your answer to that, Professor Vincent?
No, but it was just a question in passing, because you seem to say that PSP does not act only by activating leukocytes, but by helping the organism to get rid of the microorganism. So perhaps we need to know more about it, but it's quite interesting to see that that biomarker can have a real action against the organisms, which could be the case for CRP, although to a limited extent, and clearly not for procalcitonin, which may perhaps be harmful as a substance. Okay, that's thoughts for the future. Thank you again. We'll have a discussion in a moment, but I will now invite Dr. Gabriele Melegari, who is from anesthesia and intensive care in Modena in Italy to go on with, I'm trying to move the slide, but I think now we will speak about COVID-19 patients, and we will see how PSP could guide the clinical care in these patients with COVID-19. Gabriele?
Hello to everybody. Many thanks to Professor Vincent. It's an honor to be here with you, and many thanks to colleagues and Dr. Klein for his informative lecture. Really interesting, and many thanks to Dr. Lagadinou. So I will present the use of pancreatic stone protein with a point of care technology in the critical care unit, especially in COVID-19 patients. So pancreatic stone protein or regenerating protein or lithostatin are different names for identical 16 kilopeptide belonging the family of lectin binding proteins. PSP appear to stimulate islet B cell growth and regeneration. And at the beginning, PSP role was investigating in pancreatitis, but later it was seen that it was higher in an inflammatory state, such as trauma, peritonitis, infection, or burns, as previously explained by Dr. Klein. For this reason, we decided to investigate PSP protein in COVID-19 infection, because in COVID-19 infection, there is inflammatory storm, and this inflammatory storm could develop acute respiratory distress syndrome. It's important to underline that pancreatic stone protein is not an inflammatory protein, it's a consequence of inflammatory state. So it's important things to underline. Usually, in the severe patient, COVID-19 patient, there is a viral infection that the COVID infects the respiratory tracts, and there is an inflammatory state with inflammatory storm that could develop a respiratory failure, and it could be necessary mechanical ventilation or extracorporeal circulation assistance. In this severe patient, there could be also hemodynamic shock, and in the most severe, multiple organ failure. The mortality rate in a critical COVID-19 patient could vary from 30% to 50%, so an higher mortality. So this is the reason, because it's important to identify the most severe patients early. And this is the reason, because it's important to find an important biomarker. An important biomarker should be quickly to have the results, should have high accuracy, high predictive value, high specific and sensitive value, and it needs to be quick and easy to perform. Recently, the group of Matthias van Singer investigated the role of pancreatic stone protein in COVID-19 patients, and they investigated the use of pancreatic stone protein at hospital admissions, and they found that this protein combined with scores such as quick SOFA or score like CRB65. Combining this protein with this score, we implement the accuracy and the prediction of mortality, but it was not able to predict an ICU admissions. In the meanwhile, in Modena, we perform a clinical investigation about pancreatic stone protein in COVID-19 ICU patient. We decide to perform an analysis measuring the pancreatic stone protein and procalcitonin and C-reactive protein at ICU admissions 3 days later, 5 days later, and finally 7 days later. We perform a power size analysis a priori, and then we start the investigation. As an outcome, we choose a long-term mortality, because with 90 days mortality is the focus about a perspective of an hospital, because it's important to pass all the and survive during all length of stay. What we have seen is an higher level of PSP protein in non-survivor patients. In the mixed models, we observe an higher level in non-survivor patients, and the area under receiving operating curve was upper 0.7 in each time point relevations, with significant level every times. We enroll 21 patients, but this is enough for the sample size analysis. We found a upper level also for procalcitonin level in critical 19 COVID patients, but the area and the RURC was lesser than 0.7 in each time point relevation. Only at the beginning was a little bit upper, but it was not significant. And for C-reactive protein, we didn't have the same result such as PSP pancreatic stone protein. So PSP showed an RURC higher than 0.7 in each time point, with a significant difference between survivors and non-survivors. Both evidence were not observed for procalcitonin and C-reactive plasmatic levels. Probably the explanation of that is that PSP are significantly increased in clinical situation of infection, but as previously explained, PSP is not inflammatory, it's a consequence. So is the reason because we can choose this protein as biomarker. PSP could activate leukocyte, triggering polymorphonuclear neutrophilis and granulocyte activation. This activation could facilitate the adherence of selectins and integrins to neutrophil surface and to the vessel walls, and this could promote pulmonary edema. So this is one of possible reasons for our results, and we observed the PSP levels higher in in critical 19 COVID patients. At the end, I would like to thank Aferetica and Abionic for their support, doctors and nurses of anesthesia intensive care, and the resident school of anesthesia intensive care that help us in this research. Many thanks for attention.
Thank you very much indeed, Gabriele. This was a very instructive talk with a good application of PSP as a severity marker. And I'm pleased to see that we are now 220 participants. So it's still going up. We are more and more numerous here. And I hope to get some questions in the chat box. So could this help to decide if the patient had to go to the intensive care unit? Did you find it useful for ICU admission?
No, because we start the measurements at the hospital, at the ICU admission, not later. So we measure the PSP.
Not before, you mean? Not before. My question was.
Not before. Not before.
Orient the patients, because that's a very important application of sepsis markers, you know, to decide whether the patient should go in the ICU or not.
Now we receive the patient and we start the measurements at the ICU admission. It was not possible. It was not possible starting the measurement before for technical reason. And
no, sure, but in the future, that's a possible application.
In the future, we hope to continue to investigate the PSP measurement. We hope to stop with COVID, and we hope to start with a new type of patients. I think everybody hoped that. But we are very satisfied about this experience, this measurement. I think it's very useful. And since the beginning of the research, we understood immediately that the PSP was useful, and immediately we have seen a higher level of critical ICU patients. And that was amazing. And also, in my point of view, also the statistic calculation were very easy to perform, because the result, also observing the Excel, was immediate. You can see immediately.
Very good. Thank you very much. So now we will go to the specialist in infectious disease from Dr. Maria Lagadinou, who is from the Division of Internal Medicine at the University Hospital of Patras in Greece. So we'll see what her experience is, Maria.
Hello, good afternoon to everyone. I would like to thank for the invitation to be here among the speakers, and it's a very big pleasure for me to meet you, Professor Vincent. I decided to transfer you our experience from our centers regarding the pancreatic stone protein. As previous speakers already said, PSP is a pro-inflammatory mediator that binds to polymorphonuclears and has been shown to promote their activation in vitro. It belongs to the family of lectin binding proteins and secreted by pancreatic cells into the pancreatic juice along with other enzymes. Here we can see that PSP is in high levels in pancreas, which pancreas reacts and answers with high levels in the serum after cell damage or organ dysfunction exists. many publications regarding the usefulness of PSP, which have reported the usefulness of the biomarker in the diagnosis and evaluation of patients with sepsis, in the characterization of the severity of the infection, and the prediction of the outcome of patients with sepsis requiring ICU admission. Here is the publications in the chest in the year of 2011. It's a publication with 100 participants. The study enrolled patients with ventilator-associated pneumonia. PSP was measured upon admission and on day 7 on hospitalization. As we can see here, PSP levels were statistically significantly elevated in non-survivors, and the prognostic accuracy of PSP was too high for predicting death in that population. So PSP is a biomarker reflecting organ failure and outcome in ventilator-associated pneumonia. Moreover, PSP has discriminative properties and may allow for identification of survivors and non-survivors. Here is another publications of another philosophy. Researchers decided to connect many biomarkers, and researchers confirmed the prognostic value by this study, the prognostic value of PSP in patients with severe sepsis and septic shock requiring ICU management. And they established that a model combining severity scores with procalcitonin and PSP maybe improves mortality prediction in this category of patients. In that table, as we can see, it is a comparison of biomarkers such as PSP, CRP, procalcitonin, and interleukin 6. Sorry, and we can see that PSP is characterized by high sensitivity and specificity to detect infection, and we can see that is a bedside test that gives results in less than 5 minutes in many cases. So, taking into account all these publications, we aimed to investigate the prognostic value of PSP in patients hospitalized due to COVID-19 infections in our center, and to investigate the role of PSP in the prediction of in-hospital mortality, 20 days, and the length of hospital stay. Our study was a prospective study. We enrolled patients that were aged 20 years old and older. We enrolled 55 patients that diagnosed with acute SARS-CoV-2 pneumonia, and we measured we measured biomarkers such as white blood cells, lymphocytes, absolute count of lymphocytes, monocytes numbers, neutrophil to lymphocytes ratio, D-dimers, CRP, LDH, ferritin, high-sensitive troponin, and PSP. On admission day, we also wrote down and mentioned the use which of these patients need during their hospitalization, the need of non-invasive ventilator, and we also wrote down the duration of hospitalization and the final outcome. PSP was measured in whole blood, and we measured it using a diagnostic capsule for quantitative measurement with a point-of-care diagnostic device. Our results showed that the median age of our study population was 68.8 plus minus 14 years old. The majority of our study population were men, 51.9% were men, and the median length of hospitalization was 10.9 plus minus 5 days. In that table, which is from the paper we published, our paper was published just the week before, 1 week before, we can see the characterization of our study population. We divided our population in two groups. One group of patients who died, the non-survivors, and one group of patients who died. Our patients showed statistical significant differences in the parameters we saw here in neutrophils, lymphocytes, in the neutrophil to lymphocyte ratio, in LDH, in ferritin, and high sensitive troponin. And as you can see here, PSP was elevated in the group of patients that finally didn't survive, 107 versus 57.5, but the difference was not statistically significant. Regarding in-hospital mortality, PSP showed a prognostic accuracy with an area under the curve. We used ROC analysis with an area under the curve only 0.588. Regarding the length of hospitalization, things were much better. PSP was proved to be the best prognostic value. The area under the curve was 0.800, while other values such as high sensitive troponin, NLR, CRP, and ferritin were lower, as you can see here. So PSP performed best among the measured acute phase proteins, given the rather moderate AUC, showing the best prognostic value. PSP measurements were statistically significant lower in the group of patients who were hospitalized for less than 10 days compared to those hospitalized for more than 10 days. We also calculated the optimal cutoff value of PSP for prolonged hospitalization using Uden index. So we found that the optimal cutoff value for PSP was 51, with a specificity of 91.3% and a sensitivity of 65%. When exploring the predictive value of PSP on the use of non-invasive mechanical ventilation, we found a too low AUC. His prognostic accuracy was not very good, and here may be an answer in the question you asked before, Professor Vincent, in the prediction of ICU, in the prediction of patients that they need ICU treatment, COVID patients that maybe need ICU treatment. We didn't manage to predict patients that they will need non-invasive ventilation. So in our study, PSP measured on admission could be used for identification of patients with SARS-CoV pneumonia at highest risk of prolonged hospitalization, reflecting more severe disease and the need for intensive treatment. After reviewing references, we found that not many things have been written regarding PSP and COVID-19 infection. Here is a presentation that was presented in an annual conference for the potential role of pancreatic stone protein as early marker of bacterial infection as a complication in COVID-19 patients. They present here 3 patients with COVID-19. The first patient showed markedly increased PSP levels on day 10 with no significant changes in CRP and procalcitonin levels. And after our bronchoscopy, patients isolated Klebsiella pneumonia. In patient 2, upon ICU admission, PSP level was 287, too high, and he was not receiving antibiotic treatment. His condition rapidly worsened, and CRP levels increased since patient had a bacterial infection. CRP levels increased between 48 and 72 hours after detection of increased PSP level. And in patient 3, upon ICU admission, PSP level was elevated, and after 48 to 72 hours, CRP levels increased with no significant changes in procalcitonin levels. And when patient underwent endotracheal aspirate, was collected, and he was positive for Pseudomonada aeruginosa. Here we can see a study similar to our study, and this study was presented from the previous speaker. Here it has been reported that PSP has a high prognostic accuracy in 7 days mortality in COVID-19 patients, and this accuracy gets much better when PSP is combined with CRP, and even better when PSP is combined with clinical score CRP 65. So after mainly our work, we can see that PSP as PSP is established as a biomarker for sepsis identification, maybe we will be in the future able to create a triage based on an easily measured biomarker in order to manage resources and early apply proper treatments that will in turn improve the outcome and reduce the hospital stay. Thank you very much for your attention.
Evkaristo, thank you very much. Very nice presentation. Interesting. Now, a question to you. You indeed showed very well that it could help to identify the infection that will require the antibiotics and perhaps the source control. But could it be seen the other way around? And could you sometimes identify the patients who may have some fever, for instance, but then you look at the PSP levels and you say, well, they are about normal. They're around 40. I don't need to give antibiotics. Could we use the negative predictive value of this marker?
Thank you for the question. In order to answer this, we need to have many patients to establish something like this.
Yes, so you cannot say anything about it yet.
No,
we need
not
more
yet.
data.
Yes.
All right, yet. Very good. So we can now open the discussion with the others. And one of the questions is indeed, could the others appear on the screen as well? Yeah, very good. One of the questions indeed was, could we have the result relatively quickly? But I think we have addressed it. It's about 5 to 7 minutes to have the result, isn't it? And it's a point of care instrument, right? You can bring it nearby the patient. You can bring it in the ICU, wherever that is. Agreed? Should we perhaps use it in the emergency department before we use it in the ICU? I mean, for the patient who is in the emergency department already, because we spoke about the ICU, but not much about the emergency department.
May I have a position?
Sure, go ahead. Yeah.
In Greece, we have some hospitals, I think in Thessaloniki, some hospitals have this, the instrument we can measure PSP in the microbiology department. It's a routine, it's something routine. In our hospital, we try to have we try very much because you know about the economical problems we have. We try to take the PSP measurement in our division and have it bedside and measure the PSP bedside.
Yes. Yeah. Holger, would you like to say something?
Yeah, maybe an interesting point would be, and this is what we were actually discussing for a future study is that we should measure it like not once a day, but maybe every 4 hours or something. So to really and early identify, because I think that data that we that we've shown today, they really support the timeliness or the timely advantage of this protein. So it would be interesting to find out in a future study, once you measure it like several times a day, hopefully the hospital pays for it. But if you could identify patients who are on the way to a sepsis much earlier.
That would be a very nice application, because it's not sufficient to say that those who will not survive have higher level than those who will survive, because at the individual level, even if you say your patient has a high likelihood of dying, you will say, yeah, but I will still treat that patient. I will not give up because the marker is very high. So, but however, see where to orient the patient, see whether we need to give antibiotics when the patient is not on antibiotics, or perhaps change the antibiotics, call the surgeon, call for an abdominal CT, etc. These are very important implications. And for this, the time course would be very important. And I fully support what Holger says, that if the half-life can be relatively short, then we could have serial measurements. Gabriele, any comment about this, about serial measurements?
I think the next step is to show to decision maker these results about this experience, and also continuing the investigation about PSP, especially in the in surgery unit for emergency surgery condition, or in the emergent explained in the emergency department, because we have the opportunity to measure the PSP protein with the point of care technology. And as it happened for thromboelastography, we can have the measurement immediately in 7 minutes, and we can have a quick and easy analysis, not waiting procalcitonin from laboratory exams. So this is a big opportunity. We hope to continue to investigate in this direction, because I think PSP protein could substitute the procalcitonin or or C-reactive protein, especially because we have a point of care technology. So with a point of care technology, we need only advantage. One machine in the department, and all colleagues can go to have analysis with a quick analysis, easy to perform, nothing difficult. 7 minutes it needs. So I think it will be the future.
Okay, we have only a few minutes left. Since you mentioned the repeated measurements, Maria alluded to the costs, Holger too. Do we have some idea about the cost? I'm not asking for a precise figure, but what is the kind of costs?
Almost 90 euros. Almost
90 euros
for each analysis. I think the decision maker, if make a big investment, can treat the price.
You are from Switzerland, so you would be ready to make a number of measurements every day in your patients.
But
I'm asking Holger. I like the others to say what they think.
No, I think once you compare it to the costs of procalcitonin, where we pay in Switzerland about, let me think, I think it's about 80 to 100 francs about this. So it equals the price with the pancreatic stone protein.
It's cheaper. I mean, it's about 15 euros, 15 Swiss francs.
Say it again, sorry?
It's about 15 euros or Swiss francs.
The PCT?
PCT, procalcitonin. Yeah.
Oh no, so at our hospital it's about 80 to
Oh, yeah.
between 80
Oh,
to
okay.
100.
Yeah. Do you think we could combine it with PCT or with CRP, Maria? Is it a good idea to combine these biomarkers instead of selecting just one?
I think it could be a good idea to combine them, and we are managed to have a protocol combining procalcitonin, interleukin 6, and PSP in our center now. The problem for us is that they are very costly.
Yeah, of course, yeah. Gabriele, would you be interested in combining these markers? Or you would like to have only PSP?
I think the PSP could be sufficient. Really, I'm very satisfied also because I followed all the research and I was amazing. I was amazed about the results, and I think the most difficult things is convict the decision maker that this cost is not enough and is not too much, especially because avoiding 1 day of length of stay in ICU, it's more cheaper if we avoid 1 day of ICU, 1 day in length of stay of ICU. It's more expensive.
Oh,
so
of course, yeah, definitely, yeah, definitely. Yeah,
as you told you before,
there is one person here who confirms that the price of procalcitonin in Switzerland is quite high. It's more than 80 Swiss francs or 80 euros. So they fully agree with Holger. Now, returning to the possibility to limit the antibiotic therapy. Could we use the serial measurements to identify the patients in whom we could stop the antibiotic therapy and therefore limit the pressure of antibiotics and the emergence of resistant organisms? Maria, that may be for the infectious disease person.
Yes, of course, in case of having enough data.
No, sure, but it would make sense. Holger,
yes,
would you agree
that
it could make sense in your practice as well, in surgery, Holger?
Yes, of course. Now, a thought of our center is to use PSP in patients with cancer, because every fever in cancer patients is not infection. We would hopefully we would like to measure PSP in cancer patients with fever. So we want to exclude a patient, because every patient with cancer that comes in hospital takes an antibiotic. We would like hopefully to measure PSP and find those patients that they really need antibiotic. Those who won't have elevated PSP, we will stop treatment with antibiotics.
Okay. Yeah. Holger, your last comment?
Well, hard to tell on that issue. We don't have any data, so to be honest, we cannot say anything.
So that's indeed, there are still a lot of data that could be collected and analyzed, which is exciting indeed. And it seems that PSP is a very interesting sepsis biomarker that can be measured at the bedside with point-of-care testing. And hopefully the measurements could be repeated quite easily over time. So I think it's a very interesting subject, and I'm sure we'll hear more and more about PSP in the months to come. If you come to Brussels next March, there will be several talks on this. Actually, people are very excited about your results and other results. So I think it's really exciting, but our time is up. And so I will definitely thank you for your interesting presentations, the public, of course, for their participation, and above all, Abionic for having allowed us to have these discussions. So more to come. Very interesting stuff. Thank you very much. Thank you. Bye-bye.
Bye.
Thank you, everybody.
Bye. Bye.
Bye bye.
Bye-bye.